Hi, my name is Ron Blankstein. On behalf of the ACC Cardiovascular Imaging Leadership Council, it's my pleasure to welcome all of you to this webinar on advocacy. Advocacy is certainly an area that's very important to the college and to the imaging community, but it's an area that often many of our members feel like they need to learn more about. So today we have brought to you a lineup of the stars of advocacy and representatives from all the imaging societies. And hopefully we'll learn a little bit in the next 60 minutes about advocacy. So without any further introduction, we'll turn it over to Sam Jones, who will be talking to us about the importance of advocacy.
Great. Thank you so much, Ron. It is really a joy to be here and talk about advocacy. I am Sam Jones, the electrophysiologist in Chattanooga, Tennessee, and I chair the Health Affairs Committee for the ACC. And many people ask me, why do I get involved in this? I mean, is there anything we can really do about this? Nothing ever actually moves, nothing ever changes. And I would really push back on that. I think we are able to affect change, and I'll talk about a few things. The other thing I will say is that if you look around you in your hospitals and your practice, you see the same thing I do. I mean, we're burned out, right? You look at your clinicians that are working with you, and people just feel the sense that we're not able to practice medicine the way that we know that we should. We can do better for our patients. We can do better for ourselves. And unless we stand up and we have a voice, nothing is ever going to change. So I think perhaps more so than any time in my career, this is the time we have to do this. About 6 weeks ago, we had the ACC Legislative Conference in Washington, D.C., where we had 400 of our ACC members get together and talk about what are the issues that are facing cardiovascular medicine. And it didn't matter where you're in the country they were coming from, or if they were EP or interventional or imaging, everyone said the same thing. These regulatory barriers are more than we've ever seen before. We are experiencing staff shortages. We're still dealing with issues with the pandemic. We have so many barriers coming at us. In addition to that, we know that the physician fee schedule continues to be a problem, where it seems like every year they continue to cut physician salaries. And meanwhile, our hospitals continue to deal with a lot of issues as well. It's not uncommon, whether you're at Cleveland Clinic or Mayo or Ascension, they're reporting billion-dollar losses. And we feel that because when we try to get supply chain issues, we can't get that. We need to learn the language of what we're asking for. So on our call today, we really have those experts that you mentioned. They're going to help us understand what is a RUC process, what really goes into physician fee schedule, so that when we go advocate for this, we can really make some change for that. Any of you that have some electrophysiology colleagues, they've been dealing with this in spades right now. It's been really difficult. Those who weren't yelling at the top of their lungs may be in the fetal position in the corner because they had up to a 37% cut in AFib physician fee schedule. These are just draconian cuts. Now, we were able to claw that back through effective advocacy, maybe not to where it was 10 years ago, but we were able to get that back about 11%. And I think that was just due to advocacy. There's numerous other issues. Talk about appropriate use criteria. This is something that the imaging world really deals with, and the ACC works with all of the imaging societies to make sure that a law that was put in place 8 years ago that really doesn't make sense now, that is too complex, that is too burdensome, puts too many barriers, and has too much cost associated with it, that we continue to advocate for how do we push that back. And this is another area where we've actually had some great success. So I think that wherever you are in medicine, realizing that the challenges are many. All right, we have to get involved, we have to have a voice, and we have to make sure that we understand these concepts. Today, we're going to hear from all of the different components of imaging, but I strongly encourage you to get involved and understand we have some short-term fixes, but the ACC really wants a long-term solution for this. We have to get involved in value-based care. And this is where I think imagers, probably more than anyone else, what you guys can do for coronary artery disease, for heart failure management, and really just show that we're not having pretty pictures, but we are really demonstrating cost-effective care. This is how we're going to really bend the cost curve, because I don't think that always our payers understand that. And that's one of the last things I would leave you with. There is such a disconnect right now between what our guidelines say, what we know we can do to patients, what we can do for patients, and what the payers and others are actually allowing us to do. we have to get in there. One of the key things we did, again, at Legislative Conference was working on prior authorization requests. Making movement in that doesn't happen without advocacy. So I would say let's make sure we understand the language, we have a voice, we get together in this very critical time and make sure that we affect the change so we can do what we need to do for our patients. I'm going to turn it over now to Jim Blankenship. I've known him for a while. He is known throughout the world of cardiology and interventional cardiology and can tell us a lot more about the RUC process and what that really means and why should we pay attention to it.
Thank you, Sam, for that introduction, and thank you for that excellent introduction to advocacy and the important role that it plays in the professional lives of ourselves and the ability to provide services for our patients. Very important. I've been asked to talk about what determines professional fees, and I have knowledge of this by virtue of being the American College of Cardiology's representative to the Relative Value Update Committee for the past 20 years. In that capacity, I have been involved in valuing most of the services and procedures that you use in your everyday practices. I'm going to speak about three particular aspects of this. The first is the AMA Specialty Society Relative Value Update Committee process and how those recommendations then go to CMS and then how that influences reimbursement by private insurers. So first, let's start with the AMA Specialty Society Relative Value Update Committee process, and that largely is dependent on surveys. Surveys are sent whenever a procedure is revised or if a new procedure is added to the list of procedures we do, it has to get valued. And the way that is done is to send surveys to members of the societies that perform these procedures with a request to fill out the survey. And this is what the heading of that survey looks like. I want to emphasize that the values that we end up with are based on time and the intensity of the work required to perform that service. So this is taken directly from a survey. This one involves a non-cardiac procedure. But the point is here that as part of the survey, you're asked to fill in the pre-service time, the inter-service time, and the post-service time. And the pre-service time is the time before you start the procedure. The inter-service time is the time that it takes to do the procedure, and post-service time is afterwards, such as generating a report and communicating with referring doctors. Another aspect of it is intensity, and this is the part of the survey that asks about intensity. It breaks it down into mental effort and judgment, technical skill and physical effort, and psychological stress. And that generates an average intensity score, which is then used in valuing it. The last and one of the most important questions on the survey is your estimate of the work RVUs required to accomplish that service. And then the way this all fits together is that you take the work RVU, and in this case, we put in just one RVU, and if the inter-service time is 10 minutes, then you have an inter-work per unit time of 0.1. And just to give you an idea of the intensity of some different services, I've given you some examples here. I would draw your attention to the numbers in red. That's the IWPT, or the inter-work per unit time. And you can see that in cardiology services, it goes from a low of 0.0292 for reading a Holter monitor, and then it goes a little bit up for cardiac MRI without and then with contrast, and then a little bit higher for cardiac MRI for morphology and function. But you can see that the intensity is judged to be about that of an office visit. In the intermediate range, we have several other studies that you perform, and you can see here the range of intensity is a little bit higher. I think interestingly, the coronary CTA is rated as about the same as a head CT with contrast. And then finally, at the upper end of the spectrum, you have liver transplant and intracranial surgery for aneurysm and percutaneous cerebral thrombectomies. And then the interventional cardiologists have topped out with STEMI stenting at an IWPT of 0.15. So after all of this data is taken into account, the Relative Value Update Committee makes a recommendation to CMS. Now, in the good old days, CMS would take that recommendation and implement it about 95% of the time, but CMS has gotten more intractable, And now they accept it about 80 to 85% of the time, but in some cases, they will reject the RUC's recommendation and just come up with their own recommendation. And when they provide the rationale for that, you can see that it's often very hard to defend that from a medical standpoint. This is an example from the RUC database, and you can see this is for transesophageal echocardiography. And down at the bottom, you can see here, this is the case where CMS did not accept the RUC recommendation. And again, there are many of those. Now, how do you convert the RVUs into payment? That's done by the so-called conversion factor. Every year, CMS sets a conversion factor, and for 2022, currently, it's $34.61. That is quite a cut from last year when it was about $36, and over the past decade, it has vacillated around the value of $36. So we took quite a cut this year, and of course, we don't know what it's going to be next year. So the values that CMS implements do influence private insurers, and generally private insurers will pay on a per RVU basis, but they will often pay much higher in the range of say $50 to $70 or even in some cases up to $90 per RVU compared to CMS's $34 per RVU. So how do we advocate for imaging? I think the first thing is to educate members about the RUC survey. One key point is that oftentimes the values are based on just 30 survey responses. So if you're filling out a survey, you may be one of 30 people that determines the value of this particular procedure going forward. It's important to remember that you base your survey responses on the typical patient, certainly not the easiest and also not the hardest, and to include all of the work involved with the service. That includes comparing past studies, looking at the clinical history, generating a report, correcting it, signing it, and communicating with the referring doctor when that is done. A second very important point is to understand the entire strategy behind CPT coding and the RUC process. For instance, anytime that a code is resurveyed, it is at risk for going down. It is extraordinarily rare for a resurvey of a code for any reason to lead to that code's value going up, but it's very common for it to go down. So anytime that any change in the code leads to a resurvey, you're at risk for it going down. And then, as Dr. Jones mentioned, our electrophysiology colleagues have been brutally awakened to the risks of bundling, which is what happened when some of their codes went down 30 to 40%. And now the interventional cardiologists are learning that lesson because intracoronary lithotripsy is a new code, and the introduction of that new code is forcing a resurvey of all of the interventional codes. And we will be very lucky to come out without a significant reduction in the value of all of the interventional codes. So it's important to understand that there's a definite strategy behind developing new codes and resurveying or trying to prevent resurveys. So with that, I'm going to pass the baton to James Vavricek, who's the American College of Cardiology Director of Regulatory Affairs. He is an absolute expert on this, and he's going to be talking about what determines technical fees. Thank you.
Thanks for that introduction, Dr. Blankenship, and thanks, Dr. Blankstein, for inviting me to participate in the webinar this evening. I'm going to pull up my slides here and just talk to you briefly, building on some of what Dr. Blankenship went through about the RUC to make it a little bit more broad in reference to the fee schedule and also the Medicare outpatient payment system. These are some of the elements that you had thought would be of interest to people wanting to understand the way payment works and also look for ways to get involved in advocacy. So in the fee schedule, payment is driven by just three components fundamentally that we're going to be able to most have an input on, really only two. Dr. Blankenship just went through physician work, but also the other element that we do look at inside the RUC process and in other ways with the agency is practice expense. And then finally, there is a factor for liability insurance. In the physician workspace, as Dr. Blankenship mentioned, there's the technical skill and effort, some of these kind of intensity questions that he pointed at, mental effort, psychological stress, and as he pointed out, time. And this kind of goes into the information that the RUC looks at for assessing work RVUs, and it's also compared against everything else in the fee schedule. To go into the Wayback Machine, when Congress passed the law that created a fee schedule back in the late 80s instead of previously when services were paid on a usual and customary service. This is the sort of system that was set up. So now we look at physician work and try to develop a work RVU, and we'll come to a little bit more about what that looks like at the end. The practice expense is everything that you might think of the costs inside your practice. It's going to be the nurse that sees the patients, potentially to like get them teed up for you, staff who cleans a room, people who are entering imaging or reports into the EHR, supplies, everything from a Band-Aid that they account for 7 sheets of exam table paper for every patient that comes into your office. And then finally, the equipment, that's calculated down to the minute. So the agency and payers are looking at how many minutes a scanner is in use, for instance. And then I don't have a slide here for the PLI, but CMS does some canvassing of rates for the various different specialties to assess a liability factor that goes into the payment system also. So, so here you see those 3 elements: work, practice, expense, liability. They are all also adjusted for geography to some degree for the last, 15 years. I think there's almost always been a floor of 1.0. In theory, these can go below 0. And then, in more expensive areas, they go well above 0. The geographic adjustment on the practice expense in Mississippi is a lot different than that of New York City. So, things like that are adjusted. And that determines the total RVU. And that total RVU is run against the conversion factor. Dr. Blankenship just previewed how that CMS makes that assessment for payments. This is the number in 2023. So, if a service has a work RVU, has a total payment RVU of 2, it's going to be 2 times this is the physician fee schedule payment amount. In the OPPS side, there's in some ways more complex and in some ways less complex payment mechanism. This is not my slide, by the way. I would give credit to MedPAC for this, to try to condense the very complicated OPPS system into one flow chart. Similarly, they have a conversion factor, they have payment weights, but the thing to keep in mind here is really the second kind of box on the left that says adjusted for geography factors, and that's where we have the hospital wage index, and then we have the non-labor related portions of services provided in a hospital. And this is all captured in reports, cost reports that facilities develop and submit to the agency for rate setting. And so payment in the hospital setting is a little bit different, where the agency is really able to look at cost reports and say, well, here we have a list of all these things that cost about $200. They're all CT imaging, for example. We're going to pay them all the rate. And so things get put into a bucket of similar services, things that are thought to have similar costs and that are, in theory, also at least somewhat clinically similar. And so this is going to be for services provided in the facility setting. It's just going to be the overhead for the staff and supplies and equipment. But in the facility setting, if the hospital is covering those costs, then the only payment to the physician or the clinician is going to be for the work component and a portion of the PLI, but not for the technical component that is the practice expense. So, and the same thing applies in the ASC setting, actually. I don't think that there's much imaging really in the ASC, but for anyone who's interested in this, looking at the way that services are set up in their facilities, you can see the OPPS conversion factor, and then you can see the ASC conversion factor. And in a nutshell, the ASC is going to be about 60% of the OPPS setting any given year. So finally, just a couple short examples here. I condensed down just some of the sort of information that's buried deep in the CMS website for the family of coronary CT codes. You can see the relative weights, you can see the payment amounts, and you can see that they're packaged into different APCs. The APCs are these groups I was talking about that kind of cluster similar services. the list of, for example, APC 5571 is very long, but it's mostly CT type services. So thanks, Dr. Blankstein, for the chance to speak to you all tonight. I'm going to go and hand it off to Mike Salerno, who's going to start speaking from a little bit more specific perspective on what CMR looks like.
Thanks very much, James, and it's really a pleasure to be part of this webinar with experts in advocacy. So I'm going to provide some CMR perspective also on behalf of the SCMR. And we were asked to address a couple of points. So one is what our current payment rates are. And the MRI, we basically have four main codes: cardiac MRI without contrast, cardiac without contrast with stress, and then cardiac MRI with and without contrast. This is by far the most common code used. And then cardiac MRI with and without contrast with stress, which is the most common stress code. We also have a one add-on code related to velocity flow mapping. And here I show the MFPS reimbursement for 2023 as compared to 2022. And what you can see here is pretty much across the board, we're seeing about a 6% reduction in the payments. This is also similar for the OPPS, where the situation for without contrast with stress, which is really a code that's not used all that much, and for the other stress code, we saw a slight increase compared to last year as compared to a loss for CMR with and without contrast 5561, which is our most commonly used code. One of the things, just looking back, this is OPPS, but it's the same for the medical fee schedule, is that if you look where we are now as compared to where we are in 2015, there was a 24% absolute reduction in payment for CMR with and without contrast for OPPS. And this is in actual dollars, not inflation adjusted, and a 30% absolute reduction in payment for CMR stress with and without contrast. So not only is there an issue over our current reimbursement, our reimbursement is actually significantly worse than it was a decade ago. So what are the big challenges for us? Access. So MRIs, as some of our other imaging equipment as well, are fairly costly. So that creates a barrier for a practice to, say, have their own MR scanner or a cardiology department to have their own scanner. MR is a resource typically used across different elements in the hospital. So access to slots for cardiac MRI as compared to other MRI that could be done on the scanner. We have some challenges over the duration of the studies and complexity of studies, which could be addressed to potentially make things more efficient, effectively somewhat improving access. Reimbursement, I've already mentioned. When an SCMR survey was done, lack of adequate reimbursement was the #1 complaint for cardiologists in the US. There's also declining reimbursement. And then there's an issue related to cost capture, so reimbursement relative to other cardiac imaging, considering the cost of an MR scanner. So as an example, an MRI scanner is more expensive typically than a SPECT scanner, though the reimbursement is twice as high for SPECT with similar other things that are similar. In terms of advocacy, we really need more support from ACC and ACR, particularly given that this is still a small percentage of all MRI that's being done and of all cardiovascular MRI. And then it's important to note that most CMR practitioners also do CT echo nuclear. So we all have a vested interest in all of cardiovascular imaging being adequately reimbursed. And finally, in terms of the challenge, I think this issue over cardiovascular imaging as a coherent specialty with a coherent voice across all these modalities rather than a pattern of everybody for themselves. Just in looking at access, this is based on CMS data from 2019, showing that there are some areas where you can get a CMR scan pretty easily. However, there's a gap in the middle of the country, and the high cost to get into doing MR and the low reimbursement is really not helping the situation. So what are some potential solutions? In terms of access, as CMR, as a society, we're working on reducing the duration and complexity of studies. The idea of can we work on having increased slots, and then potentially a future direction for lower cost scanners and CMR dedicated scanners. In terms of reimbursement, we've thought about issues over potential other add-on codes with the caveat that James mentioned to really account for the additional work that we're doing in many of these studies. More strategic advocacy, and then adequate cost accounting to really look at what are all of the costs associated with providing the service, which I think may be something common across the different modalities. And finally, in terms of advocacy, I really think we need to have a common voice for cardiovascular imaging at the level of ACC, and I think it's really great that Ron and the Leadership Council put together this webinar to really talk about them. We need to promote cardiac MRI as a high-value, cost-effective imaging technique, which may be more expensive on the front end, but may save in downstream tests. We need more representation of CMR experts on guideline committees to make sure that people are aware of the data when guidelines are being created. And finally, increased recognition of cardiac MRI and the guidelines, which has improved over time. So thank you very much for your time and your attention. And I'm going to hand over to Dustin Thomas, who's going to talk about the CT perspective. And he's obviously been very involved in advocacy for CT for a long period of time.
Great. Thank you so much, Michael, for that generous introduction. So as you said, I'm Dustin Thomas. I'm a multimodality imaging cardiologist from Fort Wayne, Indiana, and immediate past chair of SCCT Advocacy Committee, and I'll be talking about some of the efforts, current issues we're facing with cardiac CT reimbursement and some of the future efforts we're implementing to correct those. So historically, as you can see, and Mike just showed some similar data for SCMR, we've seen over time, and just to orient you to this graph, so on the left side is the payment rates in dollars, on the right side is frequency rates, which is pertinent to the blue line. And as you can see, as the guidelines have incorporated coronary CT appropriately, more readily here in recent years, and the data has grown, the frequency or the utilization of coronary CT has gone up and to the right, as you would expect. But unfortunately, we've seen kind of decrements in the payment rates. And as you can see, 5571, as James alluded to at the end of his talk, is the payment bin that all the contrast-enhanced cardiac CT codes are allotted to currently. And as you can see, historically, 10 years ago or so, the geometric mean cost for coronary CT scanning was actually less than the payment rates for 5571, but due to a number of rule changes and things that are beyond the scope of this talk, that those curves have flipped. And in fact, as the frequency of the utilization of these codes has increased, the reimbursement has decreased. So we also talked a little bit about 5571 as a family of codes, and this is just a list of some of the most frequently used codes in this particular family. And what you can see is that there are a lot of CT codes that are single organ system codes, and this is the similarity that CMS uses to maintain coronary CT in this current APC. But as you can see, the frequencies are just fundamentally skewed towards chest CT scanning, both for just plain chest thorax with contrast, as well as CTPE studies. And there's just really no reasonable method with which coronary CT could fundamentally change its costing and reporting to impact the reimbursement rates in this particular APC, which is why some of the efforts that we've entertained and that we'll talk about here at the end of the talk have been pursued. And really what it boils down to is that CMS methodology simply does not account for the complexity of performing a cardiac CT scan when compared to these other single organ system CT scans. We actually did a study, and this was published in JCCT a year ago or so, where we looked at time-valued costing for coronary CT and compared it to a contrast-enhanced chest CT scan. And what we found was that it was at least 3 to 4 times more costly, both in time for nurses and techs, as well as preparation and some of the facilities, kind of durable goods that were needed to perform these scans, than it was just a contrast-enhanced chest CT. And then I think those of us that do multimodality imaging, which is basically everyone on the call, understands that the contrast scanner, the CT scanner needed to perform coronary scans are really the creme de la creme of scanners. So any of these single organ system CT scans can be performed on almost any scanner, whereas coronary CT scanners are typically more costly and complex. And currently, we're stuck in a bit of a negative feedback loop and with CMS with respect to this. We have commissioned them several times and talked to them about these differences, but they continue to point back to their methodology as the reason why the costs are appropriate, the payments are appropriate. Shifting gears a little bit and touching on the physician fee schedule. So as Jim talked about in great detail earlier with his tremendous review of the RUC process, these reimbursement rates are mostly determined through the RUC process here. And as you can see, there's some geometric or geographic variation in the reimbursement rates and the relative value ranges for both technical fee and physician fee reimbursement for those codes. So what are we currently working on in order to improve reimbursement for the cardiac CT family? So we've engaged CMS both in conjunction with ACC over the last couple of years, at least twice a year, both in and out of the rulemaking period, to try to express to them some of the mistakes that we think that they're implementing in their methodology. We've undertaken a very aggressive approach with the congressional engagement through hiring of consultants to help us to engage with members on Capitol Hill to mostly with a message of access to care. We think that reimbursement is the single biggest limitation to access, similar to what Mike was talking about earlier with CMR. There was a publication in JACC several years back that also highlighted that reimbursement for coronary CT was the single biggest impediment to more appropriate utilization of it in commiseration with the guidelines. We have engaged CMS in the comment periods. We've tried to grow the stakeholder base and have increased the letter writing campaigns to CMS. And our messaging has been pretty consistent. We simply feel like coronary CT and cardiac CT as a family as a whole is inappropriately assigned to the wrong APC, and that in order to better reflect the resource intensity of that test, we need to be assigned to a different APC. And one of the ways that we can use CMS's methodology to better reflect that is to allow hospital systems with more explicit permission to charge and report costs for cardiac CT directly to CMS over time. We have also undertaken an effort to start looking at revising and restructuring the cardiac CT codes to better reflect some of the complexity and incorporate some of the newer technologies within reading and interpreting these scans, as well as some of the costs associated with some of the higher end scanners. And then ongoing currently, for those that have been lucky enough to receive, there's a Category 1 submission for FFRCT is underway, and RUC surveys have been sent out. So as Jim alluded to with participation in these RUC surveys, we would certainly encourage, if you get one of these, to carve out 20, 30 minutes of your time and work through these very diligently, because it's extremely important for reimbursement in the long term. So with that, I'll close and turn it over to Dermot, who's going to talk about the echo perspective.
Thank you, Dustin. Appreciate the introduction. My name is Dr. Dermot Phelan, and I'm the Medical Director of Cardiovascular Imaging at HRM Health, Sanger Heart and Vascular Institute, and I'm the co-chair of ASC Advocacy. So I'll be speaking through the lens of echocardiography for the next 5 minutes or so. And so I'm going to begin really how everyone has begun, which is really to focus on what's happening right now. And unfortunately, as has already been pointed out, the Medicare conversion factor is proposed to be reduced by about 4.5% for 2023. For ECHO as well, ECHO also saw a decrease in the clinical labor reviews that was based on the practice expense revised calculations. Now, unlike MRI and CT, there's lots and lots of echo codes. So the 933 family here, essentially, if you see the Medicare physician fee schedule, that there's been a reduction of about 5 to 6% on all of these. Now, if you contrast that then to the hops, we see about a 2% increase in those on, and these are already on a higher pre-existing baseline payment for the hops. So essentially what these are doing is these reductions are driving care, I think, from the outpatient facility into the more expensive facility-based setting. And so it's not just these costs that we're facing. I mean, there's also the 4% pay-go decrease. There's the potential end to the 2% Medicare sequestration moratorium. And so there's basically about a 10% cut looming coming up. And that's really, I think, what advocacy is, what we're here to talk about, and what we need to really address and explain what these issues and the impact this will have to members of Congress. I think one of the other things that are being discussed is MedPAC recently had a meeting and they're talking about improving payment to primary physicians, which obviously is an important thing to do. But in terms of budget neutrality, we have to understand how that potentially could impact medical specialties there. So Congress is coming up, and this is really not so much a lame duck, perhaps a stuffed duck session that's coming up, given the amount of things that Congress have to deal with in the near future, including healthcare funding, the debt ceiling, reconciliation, and with the change in Congress, all these leadership and chair positions have to be nominated. So we have to try and highlight the issues with these potential cuts coming up to a Congress that is already very, very busy. So some of the things that ASC are doing, there will be an Alliance virtual fly-in in December, basically, where members will be able to talk to members of Congress to highlight some of the issues that these cuts could actually have. You know, there'll be a grassroots efforts rollout by the end of this month, again, where ASC will be putting ASC members in touch with their local Congress members to try and highlight these issues. And ASC have written multiple letters to highlight the problems and actually also in support of some of the good things that are going on, like the Carroll legislation that's coming through. In terms of other efforts that ASC are looking at is really, and I think a large part of what we're doing here tonight is to try and educate members on the importance of advocacy, understanding things like CPT, understanding things like the RUC process. And I think a good example of this is the new 3D echo code that was came out recently, the 93319. This was a big win, but it also had some nuances with this. So ASC brought out some educational documents on this. Structural imaging is really a very complex issue, and there are many people who feel that the current payment structure for structural imaging that requires so much time and effort is inadequate. But ASC have really developed a white paper on this. This was led by Dr. Jeff Rose here, which I'd really encourage everyone to read, and it provides a history and highlights some of the challenges for this code and provides some alternatives for supporting interventional cardiologists in institutions. As I think Dr. Blankenship really beautifully summarized the challenges with trying to have these codes revisited by the RUC, and this was some data that's actually published by the RUC where, you know, when the code is being evaluated, 41% of the time it goes down, 17% of the time it's deleted, and really only about 10% of the time does the code actually go up. So the RUC really works on the assumption that the value assigned to that code is correct, and in order to change it, there really has to be substantial and compelling argument that it needs to be changed, and this has to be based on evidence. And so I think part of our job is to highlight to people the importance and the challenges with reevaluating some of these codes, and also trying to provide some education about alternative ways to, you know, recognize the work that people are doing. ASC have also been engaging with industry partners to understand future technologies and how these will impact services. And I think, you know, a good example of this is AI, which obviously is not only relevant for echo, but for all imaging and really all cardiology. But I think what we really need to do is define the value proposition for AI and echo, and then following on from that, then decide how is that paid for? Is it going to be an add-on code? Is it going to be a part of the base code, or is it going to be a new code? And I think this will depend on how that AI technology works. You know, is this AI that's assistive? Is it augmentative? Is it autonomous? And I think this is a lot of the work that we in imaging as a group, and really within the house of cardiology, we need to think through this and again propose ways that these newer technologies can be recognized. And so ASC as a group will continue to work with ACC and with all of the imaging family who have lobbyists and speak to those on Capitol Hill to make sure they understand the challenges that we as a group are facing. And so I will leave it at that, and I'm going to hand the baton to Dr. Thompson, who will be talking through the perspective of ASNC.
Thank you, Dr. Phelan. I'm going to give the nuclear perspective here. I'm speaking as the immediate past president for the American Society of Nuclear Cardiology, and I'm also involved in advocacy for the ACC as chair of the coding work group representing our interest to the CPT editorial panel mostly. In nuclear, there are some specific issues in addition to the ones that we've talked about already. The lumen conversion factor cuts also affect all the things we do, especially imaging, as a couple of the other doctors have mentioned, especially the work RVUs. For coverage reimbursement, there are issues with cardiac PET services that are carrier priced. There's a certain instability there. And an ongoing effort for PET quantitative blood flow. Some of the radiologic benefits managers don't want to pay for something that's been approved, that's in the fee schedule and been around for a number of years and has great value. And then on the issue of administrative burden, Dr. Jones mentioned it earlier on, the pending appropriate use decision support mandate. This has been around for a number of years, and it's going to increase our administrative burden. Many of us believe that it's really no longer an applicable sort of approach. I was asked to show the physician fee schedule. This is the under HOPS. SPECT, after being cut year after year, has been fairly stable this year. PET under HOPS is relatively stable also, and PET CT actually is getting an increase, one of the rare increases. And maybe we ought to discuss how that works under HOPS, why something goes up or down based on the inputs. Here's the physician fee schedule. You might notice the specs a lot lower. The actual price paid is not as big a difference as shown here. This price does not include the price of doing the value of the exercise test or the radiotracer, or if you use a pharmacologic stress agent, that agent. Now, cardiac PET is carrier priced. When this was revalued and came into the books in 2020, it turns out that it was very hard to get good data for office-based cardiac PET, and CMS agreed with our request rather than what would have been just a very draconian cuts, agreed to let it be carrier priced, and it's worked out to be pretty stable. And so most of us are not too unhappy with the carrier pricing for cardiac PET and PET CT. And there are some isolated issues, some carriers that want to propose a very low price. The updates, for example, for the technical fee don't necessarily follow the HOPS, but for the most part, it's been relatively stable with some isolated issues. The issue of our code for PET, absolute quantitation of myocardial blood flow, has been a challenge getting coverage from insurance providers, especially radiologic benefits managers. If you're not familiar with this, it's a absolute quantitation. So we add the time domain to the flow on a PET study. And here's one study on the right panel showing just the enormous prognostic power of this tool that in people that have a little bit of ischemia based on the relative perfusion images, or no ischemia or a lot of ischemia. It really separates those who have a good prognosis from those who have a poor prognosis. Very powerfully helps us not miss people that have severe disease, makes the test more sensitive and powerful. And despite this data here, the study has 12,000 patients. We have some radiologic benefits managers say that it's experimental. One of the more egregious ones is Evacor, and here's their report last year that it's considered experimental, investigation, or unproven. And then we've talked to them, and ASNIC, the Nuclear Medicine Societies, and ACC, we've got a lot of help from the ACC on this, have talked to this RBM repeatedly. We sort of got some progress earlier this year. This was their sort of partial response. I wanted to treat it like CTFFR, and we said, no, that's not how you do it. You do this on virtually every patient you do a cardiac PET study on. So we at least have them reconsidering now, and it's taken a lot of work, it's taken a lot of collaboration. And from my perspective, the collaboration between the ACC and the specialty societies on reimbursement and valuation and CPT codes has been seamless, and really we benefit from the bandwidth the ACC has, and from the expertise of people like James Vandercheck. Here's the other issue I'll mention, which is the appropriate use clinical support tool. This was put into law in 48 years ago. It's not been implemented because of various challenges. Since then, a number of other things have come through that most of us believe make this to be redundant and just a necessary complication of our administrative burdens. You might notice that this year CMS delayed the enforcement of the penalty phase. We think part of that has to do with the fact that a committee and in the budget bill of Congress, there's a report language that requests CMS to report to Congress on the challenges from implementing the AUC program. They seem to be slowing down still, so perhaps we'll get some help. It'll take a act of Congress to either repeal this or make it somewhat better. We'd also got some help with the aid of the ACC and the other medical societies from the AMA. The AMA is asked to convene a group of interest holders. And interestingly, the ACR has a different point of view. They have a decision support tool they want to sell, and they seem to have some concerns that what we might get instead is more managed care, but almost all the other medical societies on the other side of this. So hopefully with collaborative efforts, hopefully with us working together, and especially with the bandwidth the ACC has, we can get some action on this in the near future. Thank you very much. Here's my email if you have questions for me or want to reach out. And I'll turn it over now to Patricia Galaska.
Thank you so much for this kind introduction. I'm Patricia Galaska, and I've been asked just to briefly mention my role in advocacy and as an early career multimodality imager. I always ask myself, question is why? And we always have to keep in mind, why are we doing something? And as a multimodality imager, we ultimately advocate for our patients, and advocacy enables us to be heard. It enables us to influence the laws and politics. It allows us to problem solve and participate and overall reach greater community of people who truly need us. And we know that there's inequalities and disparities which exist within cardiovascular imaging. And this is what sparked my interest when we started initially looking at a calcium CT coverage. We know that it is not covered in most of the states. I wanted to know who are the patients who are able to afford calcium CT coverage, even though it's $49, $99 at our institution, and who are patients who are not able to afford it. And as what we saw, what we recently presented is that ultimately patients who come from higher, which is not surprising, high income areas or medium income areas are able to afford that calcium CT coverage and come in from a self-referral process as compared to patients who live in a low income areas. So this is what got my why, and this is why I started thinking about advocacy for these patients. We as physicians need to recognize that we bring a lot to the table to our legislators. We need to understand that our expertise is very important, and we need to start thinking about that expertise from the very beginning. As a fellows, we play a very important role in it. It's amazing to hear all these speakers today to educate us on these very important topics. And as fellows, we need to understand them and bring them out later on as attendings. The other question is how do we become involved? Once we find our why, we have to understand that there's local ACC chapters, and this is how I became involved. I became involved through Wisconsin ACC chapter. Through our colleagues, I became one of the board of counselors, and this is how I brought my topic to the table. And this is how we started to form advocacy committee, and we started discussing very important topics. We have to build community of conversations with our local legislators. We have to educate them again and make them understand or help them understand what is important to us and to our patients. There's also, so taking it from the local, and as we know this phrase, which is very common, all politics is local, we have to bring it nationally. And there's Cardiovascular Imaging Committee through ACC, which we are partaking in. And ultimately, there's the ACC Legislative Conference, which is in October, which brings all of us together and allows us to have a common language and have common conversations. So for me, as an early career, it all started during my fellowship, and I want to bring it forward, and I want to teach others and educate others to what is important to me and what is my why, and how to take it forward. Thank you. And I will introduce Dr. Blankstein as the next speaker.
Great. Well, thank you very much, Patricia. My name is Ron Blankstein. I'll be talking about the challenges and opportunities for the field of imaging as a whole. I'll start by talking about what are the challenges for all of us in imaging. And I think a common theme that you've heard from the prior speakers, or if you're doing imaging, perhaps you experience this daily, is that imaging, we often feel that we're undervalued. Multiple examples of this, but examples that emerge today are that modalities like cardiac CT and cardiac MRI are often treated as a CT or an MRI of any other organ in the body. Doesn't account for the fact that these are much more sophisticated exams, require a better scanner, require stress medications, special technologists. So that's certainly an issue, and that reflects the lower cost of these technologies. We also know that imaging is absolutely essential for the success of many of the procedures we do in cardiology, whether it's ablations in the EP lab or TAVR procedures or any other structural heart disease procedures. Yet when we use imaging to guide these procedures, particularly TEE that may be performed for hours doing a challenging structural heart disease case, the payment for that does not begin to match the efforts that that takes. And then we have new technologies that are expensive but offer a lot of value. So a great example is PET that Dr. Thompson was just talking about, and blood flow quantification with PET. Certainly new technologies like use of AI or plaque quantification or tissue mapping with MRI. There's a lot of extra things that we keep on bringing to the table when we do imaging, yet there's often not enough or not any payment for those. The other challenge, I would say, is that imagers, just like many of us in cardiology, are often not that engaged with advocacy efforts. They haven't really found either the time or the reason of why they want to do it. And it's tough because there's a lot of things we can spend our time doing. And also, at the end of the day, it's hard to advocate for everything. So I would say that the ACC has a very important advocacy agenda, but it changes every year according to the priorities. So for example, during the pandemic, and appropriately so, there was a very big focus on telemedicine. And we now have an era where there's more physician burnout, and there's more of a focus on how do we reduce prior authorization. So imaging is not always going to be on the top of the agenda for advocacy, but for some years, it certainly is an important part of the agenda. But it's important for imagers to be engaged not just in the imaging-related advocacy, but the overall advocacy of the college, because the more you're engaged in that, the more you understand the process, the more you can contribute, the more the imaging community can show that they're contributing to the overall campaign that the ACC is conducting. And I'm saying this from my own experience. When I've gone to Ledge Conference, it's always been very eye-opening to hear about the agenda every year and to learn more about it. And then the last point here, when it comes to advocacy for imaging, is that there's often this perception that we can't just do any advocacy for imaging because we have 4 different modalities and 4 imaging societies, and that they kind of compete with each other. But the reality is that there's a lot we can do together, and there's a lot of common aspects to all the imaging modalities. Into tonight's webinar, hopefully, is pointing that out. So what are some of the opportunities with that? Well, the first is to have collaborations of all the 4 imaging societies. In the imaging section, Leadership Council would be a great place to catalyze that collaboration and to help decide on common areas for advocacy. And there's many, but we have to prioritize as an imaging community. What are some of the common areas that we can all advocate for? For example, in a particular year, there might be a modality that requires more of an advocacy effort. Several years ago, it was PET, and the ACC had a very effective advocacy campaign. Maybe in a future year, another modality has challenges with its payment, whether it's CT, MRI, or echo. And I think it's important for the imaging community to get together and say, you know, we're all, or most of us are multimodality imagers. And when there are issues affecting any one modality, for all of us together to come together and tackle that. There are also imaging techniques that are common across the field of imaging or across multiple imaging modalities. So for example, an add-on calcium scan, something you can do with nuclear cardiology. In fact, in the guideline now, it states that really any stress test can have an add-on calcium score, but yet we don't have a payment mechanism for that. It was already mentioned that AI is kind of coming, and how do we value AI codes? I think that's something that many of our imaging modalities and societies will have to tackle. The other, I think, very basic technique for many of us who do multimodality imaging, how do you put together the data for multiple modalities? So if you want to integrate data from multiple imaging sources to do an imaging consult, to review all the imaging studies that a patient may have had, that all takes a lot of time and effort. Could there be a future code for that, for example? And then last and not least is what we're doing tonight, which is education efforts. I think we all need to learn more about advocacy and certainly all learn about how can we do it together. So I will stop there, and we are now going to have a panel discussion really brought together by all the speakers. And I have to first thank all the speakers, really informative talks. I know I've definitely learned from all the speakers. Let me turn first to Dr. Blankenship. So Jim, you mentioned that when you resurvey codes, there's always a risk that your value goes down. In fact, I think Dermot mentioned that only 10% of the time it goes up. So that can be kind of depressing when you see some of the values that are already going down. So why is that? Help us understand why the most common way is down when codes get resurveyed.
Well, the answer to that is that, as I mentioned, values are generally set by time and estimates of RVU. And if the resurvey is compared to the original data that led to the original value, and if either of those, either the time on the new survey is down or the estimated value of the new survey of the service is down, then the Relative Value Update Committee is quite happy to take the lower value compared to the previous value, which was set based on the previous survey. And so one of the jobs of us when we go to defend trying to maintain the current value is to explain why the time went down. One of the problems we face is that partly as doctors get more familiar with procedures, that they in fact can do procedures more quickly, and that's an explanation why times may go down, or it can just be an anomaly of the survey, just random survey responses that produce a lesser time. I did not mention, but it is true that one of the, probably the major component to determining the value is time more than intensity. And so any decrease on the most recent survey in the time is likely to lead to a decrease in the value.
You know, I might add that a couple of the speakers mentioned something about services that seem to be undervalued, interventional imaging to support interventional procedures and so forth. One tactic we sometimes do is when we know we're going to be resurveying anyway, use that opportunity to revise the services, the CPT code descriptors, in order to try to capture some of that value that we know we're missing. That way, That way, you're not triggering a downside of loss of value, but you may be able to capture some of the value that you don't have already.
I think that's one of the values a group like this come. We talked about education a lot, and I think that helping people understand the importance of the survey is key. I think people going onto the survey and kind of bragging, I can do that pretty quick, giving them the minimum amount of time they can do a procedure actually doesn't help at all. I mean, it's not that we want people to exaggerate what they do, but we need to give an honest answer for what the average time is for these. And it's a little bit depressing, Jim, thinking that some of these are being based on 30 surveys. Is there a minimum threshold that they require before they will, take into account the surveys?
Yes, it is dependent on the total number of services being provided. So, and I forget the range for ones where it's in the millions of services. I think the response rate has to be 100, or you have to get 100 responses. But for others that are, in lower ranges, the hundreds of thousands, it can be just 30 responses. Some survey expert way back said that 30 responses to a survey produced a valid result, and that has become solidified as a rock dogma that at least for sort of intermediate volume procedures, 30 is enough. But it is very sobering to think that that any one respondent may be providing 1/30th of the information that goes into providing the service, which is done tens or hundreds of thousands of times across the country. And that emphasizes the importance of every person filling out the survey.
As we're speaking, there's a survey out for CTFFR, and I took that. It actually sometimes only takes 5 or 10 minutes, but it is very important to get people to respond to the surveys.
Yeah. I actually recently got a survey. I have to say in the last 10 years, every once in a while I get a survey, and I always wonder, how did I get this one, or why did I get this one? Is there some rationale of who gets selected?
Well, in general, it's random, although for particular rare procedures, we may get a list of persons who do that, say from industry, who tracks who's actually doing the procedure. But for the procedures we're talking about here, it's a random survey of members of specialties that are known to provide that service.
Good. Well, let me turn over to Sam. Sam, you mentioned this, and others did as well, the fact that payment rates are generally trending down, but it seems that they kind of trend down for some tests more than others, and it's not always consistent even between tests which are of the same modality. What are some of the things that impact this?
Yeah, thanks so much. I think the first thing that I would say about all of these is the concept of budget neutrality that's come up a few times here. When we think about the budget itself, number one, we know the Medicare system, we get time and time again told it's going broke. So they're looking for ways to make sure that payments aren't going to increase. But when we think about budget neutrality, it's like constrictive pericarditis, right? If you have one payment that's going to increase, somewhere else it's going to decrease. Not everything is going to increase. So it doesn't matter if you have the orthopedic surgeons telling you how great their back surgeries are, and neurosurgeons, and you have everybody else. Not everything's going to go up. And so there's going to be some that go up and some that go down. One of the reasons that specifically a lot of the things that we're dealing with right now seem to go down, and the conversion factor of 4.5% was related to the evaluation and management codes. You remember how this happened last year. They changed some of the way that these were valued. As a result of that directly, the conversion factor just had to change. So that made one big cut. The other thing that we see for some of these procedures relates to how they dealt with wages. So they had not looked at wages increase over time in a long period. And so when suddenly they got around to doing it again, many of the wages that we pay for our staff had grown quite a bit. And that's a good thing. But again, because of neutrality, that means that percentage-wise of all of those other factors that were shown into some of the equations that Jim Blankenship was showing us and James Vavricek, that means those other things have to go down. Okay, so that neutrality is extremely important with all of those things. And I think also one of the things that you and Dermot also brought up was this idea of AI technologies. How is this actually going to influence? We want this to help us. We want it to ensure that we're getting better patient care and to assist us with correct diagnosis. But we also have to be very careful about software as a service. And when it comes to the table, how is this going to be valued? And again, if that's going to be valued in one way, what does that mean to the physician fee schedule and other components of it? So this needs to be done with a lot of good rational thought to make sure that we do this correctly.
Yeah, no, I think to build on that last point, AI is certainly one of those things that all the modalities, and of course beyond just imaging, we're all trying to figure out how is this going to fit in. And Dermot, one of the things you mentioned is we have to understand what is the value proposition, because AI can add cost, but hopefully it can also someday take away cost. So when you think about echo or even other modalities, how do you envision AI providing value and truly having a value proposition? What does AI need to offer for us to do it in that way?
Yeah, I think it's first important to recognize that AI encompasses a huge amount, right? I mean, there's so many things that AI means. And so it's very difficult to just use this as one concept and say that that's all it is, and that's how we're going to incorporate it into our practice, and that's how we're going to evaluate it and use it. I mean, you've got AI from, take in terms of echo, for example, you have AI where you've got assistance with image capture. So you've got technology which uses GPS, which can help sonographers or help people who've never done an echo before actually capture an image. Then you've got AI that can actually use these measurements to generate reports. You've got assisted AI, then you've got AI that can actually be augmentative, that can help with the interpretation of the report, factoring in multiple different factors. This has got a percentage chance that this patient has cardiac amyloid, for example. So these are kind of augmentative to what we're doing. I think where we really need to be careful and where we need to engage our industrial partners is because our industrial partners can really work outside of the construct of these councils that we're part of, and they can go directly to Congress and try and get codes opened up, and that can affect all of the codes. So we really need to involve them in these conversations. And I think the key, from my perspective, or I think from an imaging perspective, is to help the legislators and the regulators understand the key role of the physician in terms of the interaction between the AI and the physician. That this is generally, almost at least in cardiology, not an autonomous program that is just doing this in the background that doesn't require any physician input. Almost all of this requires physician input, and then it's just trying to figure out how do you build that into a payment structure.
Yeah, great. No, that's challenging and important topics. So I'm going to move on to another theme here, and that's the theme of collaboration and engaging others. And I'll ask here Dustin, Randy, and Mike to talk about specifically SCCT, ASNC, and SCMR. How do you engage folks? And then, of course, we'll get to Patricia, who will help us understand how we can engage fellows and early career members, how she has done that in her program. So talk to us how you engage folks. And I think for the society, things you can talk about is the fact that these are diverse communities. You have international members, you have scientists, you have industry, and you have a lot of people that frankly just don't know much about advocacy and want someone else to do it. So how do we engage them? And if your answer could just be to get them to watch this webinar, that's good enough too. So we'll start with you, Dustin.
Yeah, thanks, Ron. Yeah, I think I heard it best from one of our consultants that they talked about kind of hammering home your elevator pitch. And I think when it comes to engaging a broader audience to be involved in advocacy efforts, I think it's really important to give them, one or two lines that they can use to introduce the topic, because ultimately what it boils down to is what we do every day in the clinic room, where we engage with patients, we make decisions about, best testing strategies for patients, and we keep it patient-centered. And I think everybody can pitch that message. It's just really introducing the conversation and helping to bridge that gap between the discussions we have in the clinic rooms and the discussions that policymakers and payers have in the backgrounds, and how can we bridge that gap so that they better understand the decisions we have to make every day, and bring those two entities closer.
I would add that all of us, think about this, realize that we want every modality to be reimbursed fairly and honestly. We're part of groups, parts of medical centers, and you don't want anything to be shortchanged or treated poorly. Occasionally, we have to tone down an overzealous doctor, or occasionally you have to tone down an overzealous industry member who's speaking out, trying to advocate aggressively in the financial field, but not very often. Most of us kind of understand that. And in terms of cooperation, I will say that my observation is on things like coding and the RUG surveys and issues of the AMA House of Delegates and for coverage. Generally, we doctors that are in the cardiovascular imaging fields are on the same page, and the ACC is a great help with their bandwidth often.
Yeah, I think having educational components for the different societies is important. Actually, at every one of the ASNIC meeting, the SCCT meeting, the ASE meeting, I always go to the advocacy meetings for each of the different modalities, because we can learn things from each other. So learn strategies that work, learn ways of how to figure out how to partner together in areas where we have common interests. And although, as Sam pointed out, in some respects, it's a little bit of a zero-sum game across the entire spectrum. It doesn't necessarily have to be just a zero-sum game across the different imaging modalities. So I think the more we can work for each other, have a common voice for things that matters to all of us, and ultimately, as Patricia really said, it's all about really doing the right thing for patient care and our patients, getting people access for the studies that they need.
So turning it over to Patricia, engaging, how should we think about engaging fellows in training, early career members, both at the state level, at the national level? We're asking you the toughest question here, Patricia, so sorry for that.
No, I think you have all done a tremendous, amazing work at engaging all of us already at this point and making us understand what's important in cardiovascular imaging. I think from the multimodality perspective and from being an associate program director at this time, it's important to start early and to start educating our fellows on what really goes into these payment methods and what is important for our patients, and which, because a lot of our patients come through our clinics and through different tests, and ultimately what is the best test for the patient. But we often don't think about the reimbursement both for the patient and for us. So there's all these different things which we need to understand early on to educate others to bring it forward. So I starting early and being passionate about a topic that we truly love and you feel really strongly about, because I think that ultimately drives what you're going to do and how much further you're going to take it. So and finding those other people who are as passionate about it, what you really want to, what you believe in, and what you want to take it forward. So so finding that support around you, and this is through ACC, whether it's through your local chapter. For me, it's Wisconsin local chapter, whether it's more on the national level, finding those connections at, as we said, at those different meetings that we all attend, and ultimately we're one big community that just has to come together and advocate again for our patients.
Perfect. Well, that is really well summarized. And on that note, I want to thank all our speakers for tonight's webinar. Really our first webinar specifically on advocacy for imaging and for multimodality imaging. And I hope many of you get to watch this and learn about advocacy and join us in future advocacy efforts. Thank you.